Good afternoon, everyone. As you walk in and get settled, if you could be so kind as to look at this QR code and answer this one survey question. It is really designed to let us, as the trauma committee, understand what type of pediatric trauma guidelines would be helpful to the APSA membership. Great. I'm going to leave that up there while I introduce our topic today. So thank you all for being here. This is the APSA Trauma Committee breakout, and we're going to be talking about some imaging updates in trauma. And if you're a pediatric trauma surgeon or you're a pediatric surgeon that works at a hospital that takes care of trauma, or you're a pediatric surgeon that works at a combined center that sometimes take care of trauma, imaging is changing and the imaging guidelines have been changing, and there's a lot of information out there, so we're going to try to simplify it. We'll give you some advice and knowledge on some of the new techniques that are out there, and then we'll have lots of time for questions at the end. So our first speaker is going to be John Drouse. John is a pediatric surgeon at Wolfson Children's in Jacksonville, and this is going to be a pro-con debate on MRI use in child abuse.
Thank you. Thanks for attending our session. I don't have any disclosures. Edward Deming it was an American economist and theorist, and he's considered the father of quality improvement in American industry. He said, "In God we trust, all others must bring data." So I've been charged in the next several minutes to convince you that MRI plays an important role in the evaluation of non-accidental trauma patients. So why is this important? Child maltreatment is a document published annually by the U.S. Department of Health. And in federal fiscal year 2022, the CPS agencies received over 4.2 million reports of children being either abused or neglected. Over 2 million of these were found to be substantiated, and over 500,000 children were found to be victims of child maltreatment. Not unexpected, the youngest patients had the highest rates of victimization, and nearly 2,000 children died from abuse and neglect in 2022. Over 60% of these deaths occurred in children younger than 3 years of age, and almost half of them suffered physical abuse. So I'm going to present a lot of data for you, and I'm going to try to do this quickly. These first two papers are from our own journal, and they're a bit dated, but they compared accidental trauma patients to non-accidental trauma patients. And both papers found that non-accidental trauma patients had a higher mortality, length of stay, and ICU admittance rate. So the injury patterns differ significantly between these populations, and they advocated for early involvement of the trauma service. Similarly, in this paper from 2013, the majority of NAT patients suffered polytrauma. Outcomes were worse, and again, prompt surgical evaluation is necessary to determine the scope of injury for these children. So what we're really talking about today is abusive head trauma. In this paper, I've given you all the references. I encourage you to read later. But this was a professional society consensus statement, and you can see the AAP was included in this. Abusive head trauma has replaced shaken baby syndrome and other nomenclatures. In this paper really said that it's the leading cause of fatal head injuries in children younger than 2. It is a multifactorial etiology, and no single study is diagnostic. As we know, subdural hematomas are the most frequent intracranial lesions, and brain parenchymal injury is the most significant cause of morbidity and mortality in these kids. This paper also found a high incidence of ligamentous cervical spine injuries. So now we'll focus specifically on MRI and abusive head trauma. So this first paper looked at the usefulness of MRI for both cervical spine and brain. This was a 3-year retrospective study. They looked at 161 children. About half had MRI of the brain only, and the other half had MRI plus the cervical spine. Over a third of these children were found to have cervical spine injuries, and most were ligamentous, and 53%, over half, of the children that had the head MRI and C-spine were found to have supratentorial brain injury. They had a bilateral hypoxic ischemic pattern, and 81% of these had cervical injuries. So further focusing on cervical spine MRI, this was another study from the pediatric neurosurgical literature, and they did a pre-pathway versus post-pathway study where they incorporated cervical spine MRI into their evaluation of suspected non-accidental trauma patients. They found, not surprisingly, an increased use of cervical spine MRI, but importantly, they found an increased incidence of C-spine injuries that was statistically significant, and more patients were treated with cervical collars, and at least 8 patients were discharged home with their cervical collar. So that argues against that these are clinically insignificant findings. So further looking at cervical spine injuries, this paper, all patients, 137 children, all patients received a head MRI, and about half of them received an MRI of the spine. In this study, those that received the MRI of the spine, 59% had abnormal findings listed below, and there was a strong statistically significant association between spinal subdural hemorrhage, retinal hemorrhages, and non-contact head injuries, and abusive head trauma diagnosis. So moving on to complete spine MRI, this paper from 2022 looked at about 250 patients aged less than 3, and these were divided fairly equally, children that had head MRI plus whole spine MRI versus children with head MRI only. And they found that about a third of whole spine MRI patients showed major findings, of which half of which were localized to the thoracolumbar spine. So that brings me to this last paper, and this one is from 2017, and this is a consensus statement brought out by the American College of Radiology. These are clinical evidence-based guidelines using well-established methodologies such as grade and expert opinion. They agreed that imaging plays a major role in detection and documentation of physical injury. And as you read this paper, they give 5 clinical scenarios and give their opinion based on those scenarios. So just this kind of summarizes their findings. I won't read all of it, but MRI, if abnormal, is indicated for further assessment of post-traumatic injury. About a quarter of patients that have a head MRI will find additional diagnostic information, and then they give protocols as to how the MRI should be done. As far as the MRI of the cervical spine, these should be strongly considered at the time of MRI brain imaging, and over 2/3 of children will have unsuspected spinal cord injuries, particularly at the craniocervical junction. And again, most of these injuries are ligamentous. And as far as MRI of the complete spine, it may show thoracolumbar subdural hematoma. These rarely result in cord compression or alter your clinical management. And their recommendation was to reserve for cases of uncertain etiology. So in summary, physical child abuse is a significant problem in the United States. Pediatric surgeons are crucial in the evaluation of these children. Abusive head trauma is a prominent cause of death and long-term disability. MRI head is particularly useful in non-emergent settings and provides additional diagnostic information over CT head alone. MRI of the cervical spine is usually recommended with the MRI of the head. In about 2/3 of these patients will have unsuspected, usually ligamentous injuries. And MRI complete spine should be considered as occult injuries are increasingly common in abusive head trauma. I'll close with a quote from Sacagawea, and she said that it's amazing the things you find when you bother to look for them. As you know, Sacagawea was the Native American that guided Lewis and Clark on their expedition. She was only 16 years old at the time and pregnant.
Thanks. Thanks, John. I'm Mike Dingledine. I am the co-chair of the trauma committee. I don't think Regan introduced herself. Regan Williams, who is the trauma director at Memphis and the chair of the trauma committee. And this is one of the sessions that we envisioned from the trauma committee that we wanted to push out information to the APSA group. Thanks, John, for a great talk. Next up is Sean Larson, who is the interim division chief and the trauma director in Gainesville.
All right, thanks everybody. Good afternoon, I think, because I'm still on East Coast time, along with my tie. So the debate continues, question mark, and do you really want the MRI? So I have no financial disclosures, but I also want to say that when I was telling everybody I was going to Phoenix to give a talk, and they said, oh, what you're talking about? I said, I'm going to tell people not to do MRI for child abuse. I got a lot of judgment head shakes. So I'm the APSA Trauma Committee appointed public defender for the no MRI camp, and I'm not really the Grinch who's trying to take away your MRI. All right, so John alluded to this child maltreatment. A couple of years ago, I gave a talk, and I had looked at the 2015 and then compared it to the 2022, and it's not surprising. The number of abuse claims is going up. The risk with caregivers, alcohol abuse and drug abuse, which has also climbed since everybody's favorite virus struck. About a fifth of these patients are physical child abuse patients, which is important for pediatric surgeons. And again, what Dr. Drous said was the children under 3 represent 2/3 of the death, and I think that's the real take-home message. So the evidence against MRI abuse, here's the subpoena for MRI to appear in court. Unlike Dr. Drous said, when you don't have data, you can use circumstantial evidence. I actually looked up the definition there for circumstantial evidence, including on the Cornell Law website. And I think we all know what that is. So anybody who's been in medicine for 20 minutes could probably make this slide comparing CT versus MRI. But basically, this is a summation of all of the papers, that I kind of reviewed during the course of this. And really what I wanted to focus on were a couple of the major differences between CT and MRI, and really speed, availability, the interpretation, and then the use of sedation or general anesthesia to obtain useful MRI images. So some other considerations, things that we know, and not insulting anybody's intelligence in this room by saying that we should have, MRI is really for stable children, but I do have to remind some of my colleagues outside of pediatric surgery that it's not the place to send the unstable or sick child to the MRI suite. It is more resource intensive. There are higher indirect and direct costs, and particularly for health systems. And then things to consider. For instance, at my institution, the MRI suite is in a separate building, and you have to get to it by various tunnels, and then you have to get patted down. They also didn't find the joke particularly funny when they wanded me, and I told them I couldn't be wanded because I'd had the COVID vaccine. And so I got called to the principal's office. When your patient's in the MRI suite, you do have to be thinking about, and this is something that we often don't think about, but is how long is the patient going to be in there, and what kind of monitoring is that patient going to need while they're getting their protocol done. Also, there are specialized protocols for obtaining the MRIs that you want, so it's very different if you're going to do a head MRI versus a whole spine MRI. The availability of pediatric anesthesia, child life, and pediatric radiology may be rate-limiting steps at various institutions. There is the possibility for overdiagnosis. I do realize that we're talking about child abuse, okay? And so, but sometimes what happens is you'll get these maybe clinically insignificant findings. And then the question is the question that I raised was, did that give say, a defense attorney the opportunity to then question the diagnosis? And I actually called a public defender and had a long conversation. And I'll talk a little bit about that a little further along the lines. Just a reminder that child abuse for us is a medical diagnosis. We're not detectives, and we're there to take care of the kid and find out what injuries that the child has. And then I did come across this. I'm not, I think there's a lot of risks for a lot of things that we do. There's a lot of unknown risks, but I did read from a pediatric radiologist that said that there could be some unknown gadolinium risks because it can be deposited in the bone marrow of smaller children. Now, the argument would be if you have a child who's the victim of child abuse, it's probably important to know that as opposed to the long-term risk. The cow falling is how I feel most days, like what else could happen? So this was a paper that was looked at MRI costs, comparison to three freestanding children's hospitals. And, these hospitals were pretty incredible when you read the methods. One of them had 8 MRIs at a freestanding children's hospital. So I don't think my whole hospital system has 8. I'm not trying to, pass out a GoFundMe website or anything, but just keep that in mind that that's a resource, right? And so they looked at outpatient sedated versus non-sedated versus limited MRI. And they just took all kids under 18. So they didn't break it down by, the smaller children. And really what they found was cost was associated with the labor costs for sedated MRI. And I'll show you. And then protocol acquisition also contributed. So just very quickly, if you look at the very bottom line, the sedated MRI versus non-sedated versus the limited MRI was significantly different in price, almost by a factor of 3 between sedated and non-sedated. When you look at the cost, it was labor. And then when you look at the cost variation for the various areas that you have to do pre, during, and after monitoring for sedated MRI, it was pretty substantial costs. This was looking at sedation and MRI in children. Again, it was a retrospective study done at our colleagues from Boston Children's. They had 217 patients that were less than 8 years of age. They performed outpatient indications, so none of these were for trauma or traumatic injuries. And their overall success rate was 82%, and not surprising, age was a predictor of success. So the older you are, the more likely you are to follow directions and lay still, as opposed to when you're younger. And then the length of the MRI protocol also contributed to success. So again, short MRI, more success. And really what this shows is at the top, there's your overall success rates. Again, this is all patients under 8. If you look at the under 3 population, which is that high risk group for death, and then you break it down to that, you can see that there's a lot of missing data or low numbers. Okay, so again, your likelihood of getting a successful MRI without sedation is relatively low, and that's a major consideration. Fast MRI, I think some folks are going to talk about this, this was a retrospective study. It compared a rapid sequence MRI plus a skull X-ray showing a skull fracture versus CT non-con. They had 2 neuro radiologists independently review. They had no idea what the clinical data was. They had good inter-rater reliability. And then, of course, their argument was that rapid sequence MRI avoids radiation and reduces sedation, which is true, but is not something that is available to all centers, right? Especially a lot of, it's a newer technology and it's expensive. And then there were 6 instances that they mentioned of 1 millimeter microhemorrhage that were detected on MRI versus CT scan. So moving forward, I'm not going to belabor this, but there's screening tools. There's a lot of epic things that pop up. And then, this reduces bias, increases screening, but there is alert fatigue that can occur. In my hospital, after we did this, everybody figured out how to get around the BPA popping up. Residents are the greatest hacks, of all time. And then machine learning, we just talked about some of this. There's the artificial intelligence, but I prefer natural stupidity. You can use machine learning to create algorithms to help. It is a new technology. It's not universally available apart from the ChatGPT, which we all just saw how to treat, Mauro, as a virus. And then a fool with a tool, which is a John Drowse quote, a fool with a tool is still a fool, right? So after taking all the data together with the American College of Radiology as well as the British counterpart, this was a suggested algorithm that we came up with. So you want to get a CT scan, you want to get that ASAP for a child, and if it's normal, you can stop. Right? There's no need to go on and do additional, looking for evidence or things like that. If it is normal, but there's an abnormal neuroexam or you have an AB normal CT, then you want to get an MRI again when the patient's stable. If you get the MRI and it's normal and the child is well, you can stop there. There's no need to go further. And if the MRI is abnormal and the child is well, then they do recommend repeat MRI as clinically indicated, maybe at a future date. And then if it's abnormal and the child has an abnormal neuroexam, you should probably repeat that MRI sooner rather than later. They have a separate algorithm or kind of a suggested for the non-injured child that's presenting. Dr. Drowse covered this, and I just wanted to remind everybody that, as pediatric surgeons, we owe it to the children to take care of them, even if we love or don't love trauma. And this was the paper by Dr. Larimer, and we're the injury experts, and our goal is not to play the detective, right? And so when I was talking to that defense attorney, they said one of their favorite tricks, and I can't tell you who it is because they told me this was proprietary, but is to, if you order something not for clinical care, is where they'll shoot holes in it. And so I think what we have to do is stick to what's important for the child and making the diagnosis of the child and the child abuse. The closing arguments, I think really the punchline is that CT and MRI are compatible. They're complementary tools for diagnosis. And then I think you have to consider your local resources, the availability, whether or not you have neuroradiology, pediatric radiology, and then the clinical relevance of the injuries. And then, I think the rest is pretty much, and since we started with the Grinch, I'll leave you with the Lorax, and I'll pass over the baton. Thank you very much.
Thanks, Sean. We'll let everybody out in the audience decide what you think about MRI and child abuse, and we may ask that at the end when questions come up. We're now going to switch gears a little bit to... Who has the clicker?
I do.
Okay. We're going to switch gears a little bit and just give you an update on cervical spine imaging. There has been a few studies, both on the adult side and in the kid side, that have come out over the last year or so. And if you work in a combined center, you've probably been hearing some things that the adults are doing that are not quite acceptable in children yet. But this is Katie Russell. She's a pediatric trauma medical director in Utah, knows way more about cervical spine imaging, and is currently conducting one of the largest trials to determine how we really should clear these C-spines. And so she's going to give us an update on cervical spine imaging. Thanks, Katie.
Thank you. I think we've all seen Lucas Neff out there on a mission to take back the common bile duct, and I'm here to take control of the cervical spine. And I think that we're all on this mission. I appreciate everybody up here and a ton of people in the audience for kind of participating in all this work. If we want to talk about this, I think we first need to talk about what is the burden of disease. So how many kids actually have cervical spine injuries? So this is a TQIP study that was written out of the University of Southern California about 10 years ago now. So I do think we need a contemporary update. But basically, if you look at all pediatric trauma patients, the overall incidence of cervical spine injury is about 1.3%. I think across the literature, it's anywhere from like 0.9 up to like 2.5%, but that's approximately how many kids have cervical spine injuries. I think when we talk about the cervical spine, there's really three things we got to think about. The first is, who do we image? Which kids that come into the ER, and we've talked about this in some other sessions, but a lot of this is sometimes done before we get called as the pediatric trauma surgeons. But who do you image? Then what imaging test do you choose? And then once you have an imaging test, how are you going to clear them? So let's start with who do you image. So we were really hopeful. There's a researcher at Nationwide named Julie Leonard. She's an ER physician, and she's also done a lot of work on the cervical spine. She presented at PTS 2 years ago now. And have you guys heard of PCARN? people in the audience? Yeah, so PCARN, it's a huge research collaborative of people looking at children who have injuries and trying to figure out the best way to take care of these kids. And basically, this PCARN group, their goal was to develop a decision rule for pediatric cervical spine imaging. And this paper is currently under like the third level of reviews, and it's supposed to drop like any day, but it's not quite out yet. So this is from her abstract. But it's an observational study with 18 different emergency departments, 11,870 children, 2.3% of kids had cervical spine injuries. And of those kids, this first line, so if your GCS is less than 9, if you have like a primary survey problem, so you have an airway problem, you have a breathing problem, you have a circulation problem, so in other words, you're like a sick kid, or if you have a focal neurologic deficit, your chance of having a cervical spine injury is actually 12.7%. So we have to image those kids. And then other things that fell out in their analysis is if the kids had subjective neck pain, if they had any altered mental status, if they had torso trauma, or any neck tenderness on physical examination, they also had a higher likelihood of having a cervical spine injury. So this paper is about to come out. I would just say, everybody, we should really look out for it. I think we're always weighing this, right? In pediatric trauma, we're weighing the risk of radiation to the risk of having a missed injury. And we don't want to over-image the kids, but we also don't want to miss a significant injury. In this study, this PCARN group thinks that we can reduce X-rays from 45 to 34% and reduce CTs from 21 to 8% without missing any injuries. So again, I do think that this is a practice-changing study that should be out in the next couple of weeks. So stay tuned. But let's say now we have to decide, so we're going to image, so which imaging tests are we going to use? I think this is the best paper to date. So this is a, it's a review. This is a consensus panel. So looked at different neurosurgeons, trauma surgeons, ER providers, adult and pediatric providers across the country. And they all came together and made a consensus statement. So this was published in the Journal of Bone and Joint Surgery, which is a very reputable orthopedic journal. And this is the algorithm. And it's a little busy, but it basically breaks up into two groups. So if you're going to image, if your GCS is 14 or 15, we should be getting X-rays. And sometimes this one is like, I think we should really all think about this, because sometimes it seems easier, like you're already getting a head CT, oh, just scan the neck. But I think that maybe we should rethink that, right? So you can still get a head CT and X-ray the neck. And I don't think, sometimes it's a little laziness thing, right? We're already in the scanner, just get the neck. But I don't think that that's the right thing to do, and that's certainly not what this paper says. But this paper does say if your GCS is 8 or below, you should get a CT scan. And then the middle group is kind of where you need to use your clinical decision making. So if your GCS is somewhere between 8 and 14, you need to kind of decide, do you think this person's going to recover pretty quickly? Then you could think about getting the X-ray. If you think, oh, maybe they're going to be intubated in the ICU for a while, or they're going to be in the ICU for a while and they're altered, then maybe you should get the CT scan. And then on this study, just to kind of set up the next kind of area that we need to think about, it does recommend, so if you are an obtunded patient in the ICU, even if you have normal imaging, the recommendations out there by this consensus panel are that you should get an MRI for clearance of the cervical spine. That is not how our adult colleagues are practicing right now. So there's a systematic review that came out of East that says in adult trauma patients, you can clear a neck based on a normal CT scan alone. As of now, that is not recommended by pediatric providers. We put this in, so through PTS and co-branded with APSA, we basically put that paper into a nice little infographic. So you can find this on both the PTS and the APSA websites. And then the next step that we got to talk about is how do we clear the cervical spine? And so I think kind of like that last paper, we got to talk about the awake patient versus the patients that's not awake. In the awake patient, if you have a normal X-ray and a normal physical examination, you can go ahead and clear the cervical spine. What about if you have an abnormal exam? So you've got normal imaging, but an abnormal exam. I think there's a couple options. You can either go home in a hard collar, you can get more imaging, and these guys will talk about that in a second, or you can call a spine consult. In an obtunded patient, what if you don't have an exam, right? They're obtunded, so by definition, there's no way I can get a physical examination and see if this patient has pain in their neck. So, you've got a normal CT scan, a few things you can do. Could you clear the cervical spine? Again, that's not the recommendations currently in the pediatric literature, though it is in the adult literature. You can wait for the neuroexam to clear, but then you have a C-collar on for many days and potential of pressure ulcers, nursing complaints, et cetera. You can get an MRI or you could consult spine. So we did a retrospective review at our single institution, and we found that CT does find all significant injuries. However, we did a WIPSERC study that Dr. Jensen was the PI on, and we found that CT actually misses injuries. So I think as of now, the jury's still out, and this is why we are all enrolling in the Western Pediatric Cervical Spine Study. And again, we really appreciate all your guys' help.
Yeah. Thanks, Katie. It's great. Next up is Dr. Shannon Castle from Valley Children's Hospital talking about rapid MR and head trauma.
So you guys can kind of decide what you want about what Florida Man #1 and Florida Man #2 said about NAT and MRI, but we're going to kind of get into kind of the rapid MRI or fast MRI, depending on what you call it at your institution, and how that plays out for head trauma or for Dr. Jensen's going to then talk about the cervical spine. So rapid MRI or fast MRI essentially is something that's faster than your long multi-hour MRI. It can be defined by literally anything that's minutes compared to the traditional one. And this encompasses a whole bunch of stuff that I'm not going to get into the physics of. The most common ones you're going to see in the literature on head injury are going to be fast spin, gradient echo, parallel imaging. Essentially, they're trying to make a blurrier picture by capturing fewer slices than in a traditional one that could take multiple sequences over multiple hours. Probably the most common one you'll see referenced in the fast MRI literature for the head is going to be HASTE, which is also single shot FSE, and so that gets confusing when they're calling it different things in different studies. This is one where you're just comparing the CT and the MRI. You can see, to my eyes anyway, as a non-radiologist, the CT for this extraaxial hemorrhage looks much more obvious than on this particular fast MRI version of the head. So if you really want to get into this, if you're like one of my partners who's getting a math degree for funds, you can, not kidding, you can go to this site or find me afterward, I'll tell it to you. There's a guy on YouTube who has MRI physics explained with multiple things, and you can actually learn all this or try to. So the first one I want to point out is these are all fairly small studies, and so the jury is not completely decided on this yet. So this study looked at all rapid MRIs of in-house and transfer patients. So some of these were done at referral institutions and some were done in-house, but it was all ultimately ended up at a single institution for a 4-year period. They looked at variable MRI techniques because it varied depending on the referral institution and sometimes even the radiologist and tech. And they compared them with the CT scans, first blinded, and then the same radiologist went back unblinded and looked at the CT first and then the MRI. And then they were a subset who had GRE images as well, so a different type of fast MRI, and they blinded and unblinded them as well to see what they could find out. And essentially what they found was that it is nowhere near as sensitive as the CT scans for these patients who had both in finding contusions, hemorrhages, or subarachnoid hemorrhages. There was more sensitivity once they were unblinded. So if the same radiologist knew there was a bleed there already, they were able to then follow up on that bleed. So that's it. For those of you that use it, you'll probably see it used this way at your institutions. And with the addition of a GRE sequence, so this was a little bit less blurry, is essentially the way to think of that, the follow-ups were even more sensitive. This is another one where they were looking at a different methodology. This is HASTE, so a different type of fast MRI sequencing versus CT. This is, again, single center retrospective. They had a rapid MRI and then had a CT during the same admission. So these were not at the same time point, but they said if they didn't have a surgery or a neuro change in between those scans, they compared them. And these were only HASTE sequences, and they had 48 patients, so relatively small. But again, they found that the sensitivity was pretty low for some of these intracranial bleeds, and so they could not rely 100% on the MRI versus the CT scan. This is probably the best study, but this is limited to kids that are under 6 years old. And this was prospective. These all were consented to have a CT plus an MRI. The median MRI time for this was 365 seconds. So these were relatively quick compared to traditional one. I won't read all these, but essentially they took a very defined group of sequences that they felt would maximize the ability to read the scan. And what they found was the CT was still more sensitive than the fast MRI, but it didn't, with the addition of all these sequences, it didn't miss as many clinically important things as the previous studies had. So the sensitivity overall for any sort of cranial injury, including skull fractures, was about 93%. They did miss 6 isolated skull fractures, 2 subarachnoids, and it is limited because they didn't include anyone over than 6 in this study. And so what they concluded was essentially that you could use this for potentially for diagnostics, but this does have the problem of missing potentially clinically important injuries and definitely some that would be important to know for forensics for child abuse diagnosis. And so overall recommendation with the data we have right now is really that it's very technique dependent. You cannot take a study and assume that your scanner and your protocoling is the same. And so this is something you really need to talk to your techs and radiologists about. There is probably higher utility in using it as a follow-up scan. So you know there's an injury, you want to see if it's getting bigger because you can find it, maybe you already know it's there. Or it may limit it for child abuse purposes because you can't necessarily see those small skull fractures or small bleeds. Even if it might not be clinically important. So I think there's a lot of technology to be improved and more studies to be done on this.
Thank you, Shannon. We're now going to stick with the topic of fast MRI, but look at its use in cervical spine injury. And Aaron Jensen from University of California at San Francisco at Oakland will be presenting on this.
All right. Such a nice guy. What? Yeah, I like that. Keep going. Oh.
Call tonight.
All right, it's gonna be great. All right, I should have titled this faster MRI because MRI is not fast no matter how you do it. But I'm going to give you some tips as to how to maybe make it faster. I don't have any commercial disclosures. Thanks, Sean, for going over all the concerns and downsides of MRI. I think this has been covered thoroughly. I won't go through this. Shannon talked a lot about fast MRI. We've moved to almost exclusively quick or rapid MRI for follow-up of known TBIs. And I think that's important because your patients are probably going to the magnet anyway to get their head looked at. And just think about that as an opportunity to get a little bit of information about their C-spine when they're already in the magnet. And maybe we can come up with some ways to make this a little bit faster so that we can get collars off sooner. And the question that Katie brought up is, do we even need MRI? The adults aren't getting MRIs in untended patients anymore. They're just taking collars off with a normal CT scan. I'll bring up one case. This was the index case for all this work that we've done. This is Rowan. He's 7, car crash, femur fracture, pretty mild TBI. Came in, he does have a retroclival epidural hematoma, but his CT scan looks normal. His plain films look normal, and he's not complaining of neck pain and doesn't have any neck tenderness. Is getting morphine for his femur fracture and is a little bit altered from his TBI. So we decided, well, we're going to put him in the ICU overnight, and maybe we can take his collar off tomorrow if he's a little more clear. Has some neurologic degeneration overnight. Gets a rapid MR to follow up to see if his TBI has progressed. And because he's got to go to the OR tomorrow to get his femur fixed, we just get the MRI of the C-spine so that maybe we can get the collar off, and it turns out his head's not really connected to his spine anymore. So almost complete atlanto-occipital dissociation with no neck pain, no neck tenderness, and no neurologic symptoms. Okay, so this happens in kids. The question is how often does this happen? It's pretty rare. I think many of us have seen this, but it's pretty rare. So I'm fortunate to work with the Western Pediatric Surgery Research Consortium, and many of my collaborators are here today, and I just lost my slides. That's awesome. So let's go without slides. Is this me that turned this off, or you guys? It looks like it's... It's you. Okay, cool. All right, so let's talk about this study. All right, off the cuff. So we had 2,600 MRIs across 10 centers, 5 years, okay? And we had a really high injury burden. I don't remember how many injuries there were. There's like 700 injuries, but 15% of the cohort had an unstable injury. Okay, so lots of unstable injuries, and we defined unstable. There we go. All the stuff in that gray box on the right side. Sorry, I've had lots of caffeine today. I talk really fast. But we had a panel of neurosurgeons, and these are real injuries: atlanto-occipital dissociation, multi-column ligamentous injuries. These are things that neurosurgeons said, if you took the collar off, you put this kid at risk for neurologic injury. Okay, so real injuries. Many of these were treated just with collars. They didn't get surgery. They didn't get halos. But real injuries, 15% of the population. 400 of these kids were considered to be unexaminable or obtunded. And you can see that 138 unstable injuries in this cohort. So over half of the unstable injuries are in obtunded patients, okay? So these are the patients that really matter. And a lot of injuries are missed by CT. So we missed 28 unstable injuries. 28 kids had a normal CT scan and an abnormal MRI. So a negative predictive value of CT in kids seems to be about 83%. Okay, so this data would argue that the adult practice of clearing a collar based on a normal CT in kids is probably not a good practice. We're going through the data to try to figure out maybe we can identify a cohort of kids that can't be cleared with CT alone, and maybe a lot of these kids could be. Some more to come on that. So how do we make MRI a little bit faster, a little bit simpler? A normal cervical spine MRI for trauma is 5 to 6 sequences. This is a full diagnostic MRI that gives you all the information that you need in order to fully define and describe the injury. But I would argue if a kid doesn't have an injury, you probably don't need all 5 or 6 sequences. If you can run through and get a couple of sequences to say, this kid doesn't have an injury, you can pull them out of the magnet, and maybe they don't need sedation, anesthesia, or 30 minutes of magnet time. So there's 2 ways to look at fast MRI. One is what Shannon talked about, which is single shot or one bang studies, which lead to really fuzzy pictures. Our MRI team has tried a number of techniques to do this, and we just can't get clear enough diagnostic quality images to not miss injuries. So far, nobody is using the typical like quick shot or one shot or fast MRI for C-spine. But we looked at if you get diagnostic quality sequences, but you limit it to just the ones that you need to rule out injury, you might be able to pick up on all these injuries. And for those that don't know, we think in terms of CT scan, you run them through the scanner once and you can get all kinds of reformats on all different planes. But for MRI, if you want an axial, a sagittal, and a coronal, you have to scan them 3 times. So each view you want is another run through the magnet, right? So you might not need all that data. So we took this and we went back and looked at all of these full MRIs and we looked at limited sequences. We asked our radiologists to look at 1 anatomic sequence, an axial T1, so that you can see blood in the column. And then we asked them to look at 2 fluid-sensitive sequences, a sagittal and an axial. And they could pick the fluid-sensitive sequence that their institution used. There wasn't uniformity across institutions, but we looked at the different types of fluid-sensitive sequences. And really what matters here is how many unstable injuries were missed. So a regular T2 weighted is probably not good enough. Missed 65 injuries. STIR is pretty good, only missed 3 unstable injuries, and all 3 of those had abnormal bony injuries. So these were multi-column fractures, and MRI doesn't see fracture very well. So STIR might be good enough, but this T2 fast spin echo or turbo spin echo or Dixon sequence is a newer sequence and seems to get you all of the inflammatory change that you see on STIR with the anatomic detail that you see on T2. So most neuroradiologists have moved to M-Dixon sequences for cervical spine MRI. And we looked through and said, if you have an axial and a sagittal, and quite frankly, you probably only need the sagittal. And with that, we didn't miss any unstable injuries. So I would propose, and we've done this at our center, that ask your radiologist, what is the purpose of this MRI? If you're just trying to rule out a cervical injury, you can just send them for a 2 or 3 sequence, limited sequence MRI. If they're going for a rapid brain, you can just add 10 minutes onto the scan and get the collar off. If you need a full diagnostic MRI, that's going to take you a lot longer and probably need some sedation. We've developed a trauma C-spine MRI screen order for kids that have normal bony imaging that are going for a rapid brain. They can just go ahead and get this limited sequence so that we can get the collar off. If you do find an injury, they may have to go back for a full sequence later, or if you have a radiologist to look at it in real time and they notice that something is showing up as abnormal, they can get the remaining 3 sequences at that same time. But really what we need is the physicist to make faster MRI. All right. That's all I got. Thank you.
Okay, we have 1 minute for questions.
No questions, right?
I'm going to ask a question of the panel then. Go ahead. We got someone coming up. Yeah.
Simone Dundas Biles from Kingston, Jamaica. With this dichotomy with adult protocols and pediatric protocols for imaging the cervical spine, what is your cutoff age? I mean, you who are privy to the paper that we're anxiously awaiting the drop for, what's the cutoff age for when adulting starts?
18.
I think that's an age-old question. For all of pediatric trauma is when does the adolescents become adults and when do we decide to treat them like adults? And we don't have a consensus up here for sure. I think that it's when they've gone through puberty, that's when they're an adult. And the reason that makes that hard is it's not an age, right? It's different for every kid. But if you're examining the kid and they have all the secondary sexual characteristics that they've gone through puberty, they should probably be treated like an adult. We have 30 more seconds.
Thank you to the panel. It was a really nice discussion. I guess my name's Eric Scaife. I work under the tutelage of Katie Russell at the University of Utah. And one of the questions that Katie knows that we've struggled with is not only MRI, CT, plain X-rays, but when to add additional imaging modalities for intracranial vascular injuries. And can you help us understand how MRI helps, hurts, or how you feel about looking for those types of injuries in the setting of trauma?
That's a great question. So we're talking about BCVI. So when do we screen for BCVI? Regan, you want to take that? MR for BCVI. MR for BCVI.
Yeah, so MR for BCVI is not very good in its current state. And there's some older papers, mostly in the adult, but some that had some children in it that showed that as well. So its sensitivity and specificity are relatively low. And overall, we don't recommend using an MRI or A to screen for BCVI because you will miss some injuries. But I do think I go along with what Aaron said is the physicists are getting better and our imaging is getting better. Hopefully we would be able to do that so we could do one image that rules out the injury for BCVI as well as the spine injury. Okay, thank you everybody. I'm going to put the QR code back up. So if you don't mind, take 5 seconds and fill out this one question survey.